Hi, everyone. Is the sound good online? Okay, I'm assuming it is. So I'm Gail Kimmel. I'm just going to introduce our speaker today, Dr. Pai. And first, I just want to acknowledge that we are gathered on the traditional, ancestral, and unceded territory of the Coast Salish people, the Squamish, the Tsleil-Waututh, and Musqueam nations, and we are grateful for their stewardship of these lands. So today, I'm very pleased to introduce Dr. Jay Pai, who is going to talk to us about integrating palliative care in the management of patients with advanced chronic liver disease. And before we get started, I'll just mention that for next week, next Thursday on June 22nd, it's a special presentation from the Department of Medicine, the Innovation Committee with Dr. Christine Chapman and Dr. Andrew Ignashevsky, and it will probably be in the Herbert Auditorium, but Cameron said that that room may change. So I will let Dr. Pai start from there, and we will take questions after.
Okay, thank you very much, Dr. Kimmel. So I'm monitoring the chat on Zoom, which is where I believe most of people are. So I'll try to see for any questions, and you can let me know if there's any technical issues with the sound or picture. So I will start by saying that Dr. Kimmel asked me to do this presentation basically 30 minutes after I finished my Royal College exam, which was he just knew that it was time to get to work. But you know, the palliative care team here, including Dr. Kimmel, you know, they do very well for their patients, and I will say that they care a lot about their residents too. So when Dr. Kimmel asks you to do something, it's very easy to say hell yes. So this is the title of my presentation. I have no financial disclosures. So who am I? I will start by saying that I am not a hepatologist. I'm not a transplant hepatologist. I am a UBC General Internal Medicine Fellow, and I'll be very humbled to be able to be joining the Division of Internal Medicine in the fall of this year. And I would say that my label, which I've given to myself, is more of a friendly neighborhood general internist with a special interest in decompensated advanced chronic liver disease. And this is just a gratuitous shot of my children. So here are some key words and abbreviations I'll be using throughout the presentation today for your interest. So I've had the lofty objectives here to basically introduce and describe what the trajectory of advanced chronic liver disease and hepatic decompensation, something that we often see as internists, certainly on CTU and in our ICUs. We'll talk a little bit about how to prognosticate this condition, some of the tools we use, and looking at patients as a whole. And then more importantly is really how to integrate a palliative care approach to these patients and when to engage them in advanced care planning, as well as having those, you know, oftentimes difficult goals of care discussions. And then if there's time, we'll try to have a brief introduction into symptom management in this population, which is a very important piece that often is very difficult to do and sometimes goes under the wayside. So we'll start with chapter 1, kind of like a Quentin Tarantino movie. So I'll try to contextualize this presentation, intermittently coming back to a case presentation. So this is a 65-year-old gentleman that you see in the pre-liver transplant clinic. He has a history of hypertension, diabetes, and obesity. He was recently diagnosed with cirrhosis secondary to NASH, complicated by ascites and encephalopathy. He was recently admitted to hospital with his first decompensation of ascites, discharged on diuretics, and then admitted a month later with encephalopathy. His MELD is 20. So a bit of background. So cirrhosis is becoming more and more prevalent. I'm sure most of you can anecdotally say that you've looked after several of these patients as inpatients. And based on Canadian data, 1 in 10 Canadians is expected to have liver disease. The mortality associated with this is quite significant and has been increasing despite best efforts. The hospital burden and impact on healthcare resources is quite significant. So based on US data, these represent, you know, almost 500,000 hospitalizations per year, and certainly within the millions, if not multi-millions of dollars of healthcare expenditure. Now, once it comes to the point of someone having symptomatic decompensated liver disease, really the only option for curative treatment at that point is a liver transplant, which is really only available to a minority of people, mostly because the limited resource of usually deceased donor livers, especially in Canada. And the majority of patients will not be eligible for a transplant. And there's a significant proportion, up to 30%, that will actually pass away while waiting for a liver. So what is cirrhosis then? So basically, it is just the end stage of a chronic process, usually marked by something causing a chronic inflammatory response to the liver, so chronic hepatitis, which over time results in progressive scarring or fibrosis, and ultimately results in permanent architectural changes to the liver. And this puts those individuals at risk for decompensation or basically symptomatic liver disease. Historically, the most common cause of this was probably viral hepatitis from chronic hepatitis B and C, but certainly more recently, the epidemiology has shifted to more so of NASH, secondary to metabolic syndrome, and diabetes, as well as alcohol-related liver disease. So decompensation of liver disease basically means that you've gone from an asymptomatic disease to symptomatic, and it's usually, the phenotypes are that of portal hypertension, which is usually characterized by the development of esophageal varices as well as ascites, and then beyond that, spontaneous bacterial peritonitis, and then progressive circulatory dysfunction resulting in an entity known as hepatorenal syndrome, as well as a concurrent kind of phenotype of synthetic dysfunction, usually characterized by things like encephalopathy, jaundice, and these kind of all interconnect as well. It's not just two distinct things. And something that's becoming a bit more prevalent in terms of the character of these patients is significant frailty and sarcopenia, which do have a mortality indicator. Now, as I kind of alluded to, that there's two distinct prognostic phases to this. So again, the chronic hepatitis piece, which eventually results in compensated cirrhosis. So this is asymptomatic disease where you do have cirrhosis or architectural distortion of the liver, but the vast majority of these patients often will not know they have disease, or they will not have symptoms of it. This then progresses to decompensated cirrhosis or symptomatic cirrhosis, if you will, where patients again have those features of portal hypertension or synthetic dysfunction. And it's important to make these distinctions because prognostically it's very important. So patients that have compensated disease usually go on to have a relatively reasonable life expectancy and oftentimes will pass away of something else, whereas patients with decompensated disease are on much more borrowed time. So the median survival once you have a decompensating feature of liver disease is around 2 years. And as we'll get into, that can be certainly more rapid in development. I will mention that the transition from compensated to decompensated disease usually occurs about 5 to 7% per year. So there's this factor of further decompensation. So usually the acute decompensating events we're all familiar with are things like variceal bleeding, development of ascites, and encephalopathy. Sometimes those can stabilize with treatment, as you'll see. And then oftentimes...
Hello?
Yeah, is there a question? Okay. There's this further decompensation where you have recurrent kind of decompensating events that usually bring people in the hospital, and further kind of circulatory dysfunction. So the main things we kind of see is recurrent encephalopathy, recurrent ascites, recurrent variceal bleeding. And this is kind of like a spiral of doom, ultimately leading to death. These are the patients we often see in hospital a lot on CTU and our ICUs, and oftentimes are very difficult to kind of manage. This is a very helpful slide to think about this in a different way. So again, if you look at compensated cirrhosis, can you guys see my mouse? Yeah, perfect. So if you look at compensated cirrhosis, the trajectory here in the green line suggests that patients may have ongoing architectural distortion, but for the most part, they actually tend to do relatively well, and again, might pass away of something else, and their survival is quite reasonable here. There is a subset of patients which will start off as compensated and slowly kind of shift into decompensated territory, and the clinical vignette of this is usually a patient that will all of a sudden start to develop abdominal distension and come in with ascites. Now, they sometimes can stabilize, but again, they're now marred by a bit more of an increasing mortality signal here. And then there's this other trajectory, which is more acute, which we'll get into, and it's not something that we're often taught on in CT or internal medicine, but it's good for the learners today to kind of appreciate this because you've seen it for sure. And that's patients that have previously compensated cirrhosis that have some type of acute event, which is usually an infection, or often, an acute kind of hepatitis picture, which is probably alcohol related or sometimes, viral hepatitis related. And they'll get a very, very kind of swift decompensation here happening over a matter of weeks often. And they actually even go into this kind of myriad of organ dysfunction. Now, this is a picture of ACLF, or acute on chronic liver failure, which is very, very high mortality. And so these patients are quite dynamic. Sometimes if you take away the inciting event, they can actually do well. But the important feature here is that they never return to their baseline, and they're often on a more kind of downward trajectory here. So this is described further, and I apologize that this is a very busy slide, but it's a lot of important information. So this is the Canonic study, which basically was done in 2013 and kind of was a very large European multi-site cohort study, which basically first initially defined this concept of acute on chronic liver failure. And you don't have to get into the full details of it here. The defining features are based on the Cliff SOFA score. So you can see that there's the usual bilirubin, kidney function, Westhaven criteria for encephalopathy, coagulation, and then respiratory and hemodynamic decline. The main important thing is that these patients have features of acute decompensating events of cirrhosis, so like ascites, variceal bleeding, encephalopathy, but they also have organ dysfunction. And the main organ dysfunctions they have are things like renal failure, so like usually hepatorenal syndrome, as well as like significant encephalopathy. So when patients have those events, as well as significant organ failure that's progressive, the mortality, the short-term mortality associated with that is quite significant. So if you look at patients that have ACLF1, which is basically one organ failure, the 28-day mortality associated with that is 22%, and the 90-day mortality is 41%. This exponentially climbs up as you have more than one organ failure. And I would argue that ACLF2, ACLF3 patients are patients that are intubated in the ICU on hemodynamic support and basically have a very short window of either mortality or getting transplanted. So this is basically a feature of patients that we see often being transferred down from other centers or being worked up for urgent transplant assessments. Now, the main cause of this is usually bacterial infection, often alcohol, acute on chronic alcohol hepatitis, or sometimes hepatitis B reactivation we see. But the majority of time, it's really unknown. Patients just tend to decompensate very quickly. As I said before, like people can improve. So if you're able to kind of treat the inciting event, if it's like an episode of SBP and you give them antibiotics, sometimes people do well and they will recompensate or basically stabilize. But oftentimes people won't. So about 20% will get progressively worse. And these are the patients that will require basically the definitive management is an urgent liver transplant. And the preferred disposition for these patients actually is the ICU. So to add to this study, was a very interesting kind of study done recently called the Predict study, which is again a very multi-center European cohort study, which basically then characterized what are the different flavors of acute decompensated cirrhosis. And again, you'll all be kind of familiar with this, but may not have had the words to describe them. But there's this pre-ACLF group here, which is basically they're characterized as this very kind of systemic inflammatory milieu where they have very high CRPs, high peripheral leukocytosis. And these are the patients here that develop, they all develop ACLF within 3 months, and they all basically have very, very high mortality rates. These are the patients that go into like very dense hepatorenal syndrome, very dense kind of acute liver failure pictures with high bilirubins, and are the ones that end up in ICU. This density plot here, if you can appreciate basically, so in kind of pink orange here is the rate of infection, and time zero basically is their decompensating event that brings them to hospital. So they're all basically marred by infections which cause this, either mostly bacterial, sometimes viral. And then in the pre-ACLF group, you can see that basically they all go into ACLF in green here, and then their risk of mortality, which is in the blue, is their risk of death. So the pre-ACLF group is probably the sickest. And then there's this other feature of unstable decompensation, and that was defined as basically patients that had increasing like at least one hospitalization within 3-month follow-up. And they were mostly characterized by like significant markers of portal hypertension. So they had increased circulatory dysfunction. They had refractory ascites requiring tips. They were more likely to have variceal bleeds. And so the driver of this underlying pathophysiology was thought to be more portal hypertension related rather than inflammatory related. And these are the patients we see always on CTU, right, that are coming in with diuretic refractory ascites. They have hyponatremia. They have, recurrent kidney injuries. These patients have a lower mortality than the pre-ACLF group, but still quite significant. And then there's this stable decompensation, which again was actually the most common group here, where they would come in with their decompensating event, but then they would stabilize. They wouldn't require any further readmissions. And they actually had a very low mortality rate at 1 year. Now, the shared feature of all this is that ascites was the most common feature of their decompensating characteristic, as well as their main reason for admission. And again, bacterial infections were like very, very prevalent in all these groups. So what is the precipitating factor for decompensation? Basically, most of the time we don't know, but again, more often than not, it's usually a bacterial infection, usually alcohol-related hepatitis. And then you can get these, other myriad of things like drug-induced liver injuries, flares of underlying chronic hepatitis or autoimmune hepatitis, which is basically just a progression of their natural history. Sometimes superimposed viral hepatitis of unknown origin. So then how do we prognosticate this? So I would say that there's a number of things we can do, but at the end of the day, you kind of have to look at each one of these data points and then look at the patient in front of you and make a decision. So there are liver function tests that we're all familiar with, including the Child-Pugh, the MELD score, and then the Cliff-SOFA, which was used again for that definition of acute on chronic liver failure that we don't often use, but I think probably should be something we more commonly try to do on internal medicine, just to help prognosticate these patients, because that really will then decide for us like whether we should be actually calling, the transplant doctor on call for transfer for these patients. I would suggest that functional status and using PPS and other scales is actually very useful for these patients in prognosticating and actually providing information to them. And then you look at other comorbidities as well. So this is just a brief summary of the Child-Pugh. So it, again, uses mostly biochemical parameters of synthetic dysfunction like bilirubin, albumin, INR. It also has space for clinical decompensating events like ascites and encephalopathy. Child-Pugh-A is basically compensated asymptomatic cirrhosis, and Child-Pugh-B might be, they have a slightly elevated bilirubin and maybe some diuretic controlled ascites, but they're pretty stable. And then Child-Pugh-C is really the patients that are more quite clinically decompensated and sick. MELD and MELD sodium, as we know, again, are all biochemical parameters. The sodium was added more recently to the MELD score, mostly to as a marker of bad portal hypertension and circulatory dysfunction. So looking for that hyponatremia, which gives people extra points. And so this is more of a marker of early mortality. So Child-Pugh is again like looking at their mortality at 1 and 2 years, whereas the MELD is more of a 3-month kind of 90-day mortality to help prognosticate patients. And then the patient that we normally refer for liver transplant usually have to have a MELD of over 15 or 16 to be considered more high risk for decompensating events. This is the CLIPS-C ACLF score. And this is not in any guideline, but some of the European Association for Liver Disease articles do kind of comment on this flow chart of, when patients first come into hospital, you can prognosticate them with the CLIPS-C SOFA score. And then, if there's ACLF present, then you go down the ACLF path. And then if it's not, then there's this more CLIPS-C AD score, which you can look in MD Calc, and that helps prognosticate patients with 3-month mortality rates. You can also use kind of unique flavor of decompensation based on historical data. So whether they've had variceal bleeds or ascites can at least help give you an idea of what this person's trajectory might be. I would say that, if somebody that has hepatorenal syndrome, especially like HRS, AKI, the risk of dying in the next month is like the flip of the coin. So those patients really are either, fighting for liver transplantation if they're candidates and putting on dialysis, or you're getting ready to palliate them and have those discussions for end of life. So what about the palliative performance indices? So the Karnofsky scale is actually kind of it's like essentially like PPS is modified based on this. And so this was done by a study done by Dr. Tandon, who's a transplant hepatologist at U of A, who's been a very kind of like strong advocate for good palliative care in liver disease. And so basically they were able to do this study where they looked at the Karnofsky performance status 1 week after discharge. And those that had a very low performance status actually had a very significant 3-month mortality. And then they were actually able to make this kind of multi-variable model, mathematical model, basically with age, MELD, and this KPS score. And it was actually found to be a relatively better predictor of 3-month mortality compared to MELD and MELD plus age alone, with the area under of the curve of 74%. This hasn't been validated, but again, it's just another tool. Basically, the takeaway from this is like you can use functional status when you do see those signals of people's function declining and increasing frailty and sarcopenia. You should really be tipping, your spidey sense that this person is probably on a more rapid trajectory towards end of life. These are some other tools that are used in the British Association for the Study of Liver Disease, or the Basel group. And so they use basically, these are all just basically like clinical indicators. So there's a STIC tool and the Bristol tool, which basically look at these markers as a prompt to then potentially tip your suspicion that this person might benefit from referral to palliative care, or like more of a palliative trajectory if they're not transplant candidates. Let's come back to our case. So this gentleman now, you ask him his understanding of what's going on, and he says, well, I know my liver is not well. The team in the hospital told me that I will likely need a transplant, and if I don't get one, I'll die. I don't understand. Am I going to die? So let's talk about how to initiate the discussions about palliative care. So you're all familiar with these different disease trajectories and functional status with time. This is often what we see in kind of advanced metastatic cancer, where they will have this kind of precipitous decline towards end of life. And then with organ failure, where they'll have these kind of staccato admissions, and then with each admission, they'll have a functional decline and never come back to baseline. And, at the end, they'll probably have more precipitous decline to death. So the other transplant hepatologist I want to highlight is Dr. Neka Ufer, who's a transplant hepatologist out of Harvard, who is also a very strong advocate for integrating and making more awareness about good palliative care in advanced chronic liver disease. And so she had conducted this retrospective analysis of patients referred to the transplant program at Harvard, and basically found this relatively shocking data that in their last year of life, they have like quite a bit of significant hospital morbidity. So at least 3 admissions in the last year of life and 1 ICU admission, and they're spending like almost a month in hospital in the last year of life cumulatively. So usually median length of stay of about 13 days. 70% of these patients are receiving invasive life-sustaining support in the ICU, including mechanical ventilation, renal replacement therapy, and CPR. And this was actually very similar between patients who were listed for transplant and patients who were declined, which is actually very, very shocking. 83% of these patients died in hospital, the vast majority in the ICU. And again, these did not differ depending on if patients were activated for transplant, meaning that they had a possible organ waiting for them, or if they were declined and thought not to be a candidate. The limitation of the study was that it was only patients referred to liver transplant programs. So you can imagine that this is probably much higher for patients who don't end up getting referred. So this is a figure that Dr. Ufer had made to kind of pictographically describe this, and this basically represents kind of what we saw before with this feature of organ failure, where once you have your initial decompensating event, this is the possible trajectory where you have frequent hospitalizations, decreasing function, ultimately ending up either dying in hospital, or for the ones that are lucky enough to get liver transplants. So what about palliative care utilization patterns in this population? So from that same study, only 34% of patients were referred to specialty palliative care services, and these were all majority in hospital. The more interesting thing is that they all passed away basically less than 2 weeks after they were seen by a palliative care doctor. So you can see here that they're really only getting referred here, whereas we all know kind of best practice wise that this should be something that's happening probably much, much earlier. So this is another interesting study, basically also looking at palliative care kind of utilization. in a retrospective cohort of patients at the U of A who were actually declined for transplant. Now, their median MELD was around 20. And the reasons that they were declined are the usual. So either probably active substance use, non-compliance with medical care, progressive organ dysfunction, so they just become too sick, or they have active cancer, which is an absolute contraindication to transplant. So these patients have a very high symptom burden. So, this is probably on par with patients with metastatic cancer at the end of their life. They have very high intervention needs. So again, many requiring ICU admissions, the vast majority requiring at least 2 hospitalizations, and many requiring procedures for palliation of things like ascites. They had relatively lengthy hospital stays. Only 28% of these patients who were declined for transplant had basically been or had discussions for DNR or advanced care directives. And only 11% of these patients were referred to palliative care. So the bottom line, as I said before, is that historically these discussions are happening way too late in the process, and oftentimes they're not even happening at all. So this study is very interesting. So basically it's looking at the benefits of kind of an early palliative care intervention. And again, as we know, this is a positive study. So basically, over the year of 2013, 2014, this is a transplant center in Philadelphia. They basically had a quality improvement study where they engaged people with a palliative care physician, a nurse coordinator, who could provide basically symptom management. And then they used a quality metric to discern their symptoms at the time. And then they had follow-up again, either at 3 or 6 months. So looking at this plot here, we can see that there was a significant improvement in symptoms overall, and mostly in the categories of things like pruritus, well-being, appetite, anxiety. So these patients certainly benefited from having early palliative care intervention. So then, what are the barriers to engaging these patients? Like, why are so few people being referred? Why is it happening so late? I guess you could say that this happens in other organ failures as well, like chronic kidney disease and heart failure, which probably historically have followed similar patterns. But what about specifically in liver disease have led to this kind of pattern? And so Dr. Refractory also did a interesting cross-sectional analysis looking at this, basically surveyed a good proportion of the gastroenterologists and hepatologists who are part of the AASLD registry to see why this was happening from their perspective. And if you look at this kind of myriad of tables here, it kind of fits a story that we're all probably quite familiar with. So there are patient factors. Again, a lot of the times the trajectories of these patients are uncertain and they can vary from here and there. So we don't know if patients can necessarily predict how they're going to do. Again, we have those prognostic indicators, but it is hard to sit down with certain pieces of information and then try to extrapolate what's going to happen to someone. There's also this push to actually transplant these people. So we become kind of singularly focused on this option for a curative liver transplant. And I think patients hold on to that a lot, because why would you not at that point if you know that the alternative is then death? And then from a provider perspective, that's the same thing. So, I think there's this more of a push to focus on transplant and life-saving therapies. And interestingly, there was this belief that, if people were active on the transplant list, they should be a full code. They made the, historical error that probably many people have made before, that palliative care is equal to end-of-life care. And then interestingly, from a process perspective, when you have a busy practice, it's hard to have those conversations because they take time, and you need to form a therapeutic alliance with these patients. And then sometimes you may not even just feel sufficient to have those conversations. You may not have the training. You may not have the, ability to come across with empathy and understanding when someone is sitting there looking at you with concern about their mortality. So how do we do this then? And this is a very helpful framework that's come out in the past year or so, with support from a number of the hepatologists, including Dr. Uffer. And this is the best case, worst case approach. And this is kind of like a flavor of the serious illness conversation, but with the hope of possible transplant. There's two different flavors, basically. So, if transplant's on the table, and I use this quite frequently, and it actually is very helpful. So you can say, well, the best case is that, yeah, you get the liver transplant, you're going to be followed up at the transplant clinic, you're going to be seen often, you're going to be on immune suppression, and you're going to go back to a relatively functional state. The worst case is you get too sick for a transplant, and you're more on a palliative trajectory. And then what's most likely for you? So based on the information we know, this is what I suspect will happen. And then the benefits of this is that you get rid of all the medical jargon. So you don't have to tell people what their MELD is. You don't have to tell people, any of the other stuff that's going to overwhelm them and go over their head. You can just say it in relatively plain language. And most people actually appreciate that a lot more. The same is for patients that are not transplant candidates. So you can actually give them a realistic approach about how the next year might go, right? So for a patient that has, patient who's 80, who has refractory ascites, they're out of the age criteria for a possible liver transplant, you can say, well, we're going to try to manage your ascites. These are the possible things that could happen. We'll try to do it as an outpatient. That's difficult with the, resources that we have. You might have to come in the hospital, but we'll try to manage your symptoms. That's the best case scenario. And then we can maybe plan for end of life in hospice or on a PCU. The worst case is that, you go into multi-system organ failure, encephalopathy gets worse, and you have multiple hospitalizations and pain and all that stuff. And your symptoms are difficult to control. And then what the middle ground might be, right? So you at least prepare people for possible eventualities, that they can at least, have some faith that they know possibly what's going to happen, and gives them a bit more certainty in otherwise uncertain process. So these are just some, I think there's been a lot of momentum in the general hepatology community about the process of palliative care and the lack thereof historically. And so there's been a lot of updates in major guidelines, including like AGA and AASLD, about how to approach this. And actually the AASLD just came out with a relatively robust kind of practice guidance for managing the symptoms and engaging with the palliative care process for these patients. And this just came out last year. So I recommend, for the learners to kind of take a look probably at this one at the bottom here. And you can kind of incorporate some of those tools into your toolkit. So what is my approach? So to give you some context, so my year basically has been choose your own adventure, basically to learn kind of the management of chronic liver disease, specifically decompensated cirrhosis, and outpatient. I worked in Victoria, where they have a dedicated liver clinic where they do outpatient paracentesis, and basically it has helped to kind of decant the hospital and emerge, and it's been quite successful. And so I worked there for about half the year, basically just like exclusively managing patients with decompensated liver disease. And if you boil it down, I was just doing good palliative care, basically. That's what it is. You're managing expectations, and you're managing symptoms, and you're preparing people for a palliative trajectory. That is what it is. And it actually is very satisfying, because you can actually make people feel better, which oftentimes I think we don't have the opportunity to do a lot in internal medicine. So this is what I do. So basically, oftentimes people will come after their first admission. They'll be like our case presentation. They don't really have a good understanding of what cirrhosis is, or why they're having ascites, or all this stuff. And so there's a lot of good education you can do. So I usually discuss like what the pathophysiology of cirrhosis is. I discuss what portal hypertension is. I draw pictures. That helps. I don't often discuss goals of care, because that can be quite overwhelming, and you still have to develop your therapeutic alliance. I usually wait for about 2 to 4 weeks, mostly because that helps me get a better sense of their trajectory. So for patients that, and by and large, people are coming in with ascites, right, to these clinics. So if there's something I can modify, like if they're, alcohol related? Can I get them abstinent? And can I stabilize them? Then they might need a paracentesis or two, but then they'll stabilize and they might actually do relatively well. If it's more progressive, like something like NASH or autoimmune that is burnt out, then I know that, this ascites probably might stabilize the diuretic, but at some point it's not. And then it's going to be the question of, is this person going to be a transplant candidate? Can they get a TIPS, or should we be preparing for more of a palliative trajectory for them and potentially end of life, like an ndwelling catheter? So I usually have the discussions usually about 2 to 4 weeks out, because then I get a sense of what their trajectory might be. Are they going to stabilize or not? And then I use the best case, worst case scenario, which works quite well. And then it's just regular reassessment. The key for this is that these patients need to be seen often, because you need to know which way they're going to go, because it can happen quickly, as you saw. So within a month, if they're still requiring large volume paracentesis every 2 to 4 weeks, then I know that, the writing's on the wall that this person is sick and at an inflection point in their trajectory. And then usually at that point, I have a kind of ongoing discussion, and it helps that, you can build a sense of trust and understanding with those patients. And then they actually get to know the disease very well too. They'll do their own reading. And it is actually quite helpful for them to actually have that information, because then you can have those goals of care discussions very simply and much easier than it is when someone's coming in sick to the emergency department encephalopathic, where, it's virtually impossible to have that. And then they end up on a ventilator in the ICU. I also have a very low threshold to once patients come in with that kind of milieu of end-stage portal hypertension, HRS physiology, refractory ascites to register for BC Palliative Care benefits early. So this is a figure from a very lovely paper, Dr. Bribois. So she is a palliative care doc at U of A, who again has done a lot of work in advanced chronic liver disease. And this is something that we've all seen before. But so basically saying that at some point in the trajectory of organ failure, there comes a time where you focus less on disease modifying therapy and more on symptom management and quality of life. And these should happen simultaneously in parallel to each other, and hopefully much earlier than we have been doing. So let's come back to our case. So the patient returns to clinic a month later. In the interim, he's had a couple of emergency department visits for large volume ascites requiring paracentesis. He is still taking his diuretics. He's adhering to his salt restriction, but clearly things are not going well. He has a mild to moderate hyponatremia. His creatinine is bumped up. He's also having significant muscle cramps in his legs and trouble sleeping at night. His mood is much lower than when you last saw him. So let's move on to a quick overview of symptom management. This should be its own 1 hour talk, because this is very, very important and complex. And I don't have the time today to really go into like the pathophysiology necessarily of all these, but I think for our learners here, I think having a basic toolkit to manage some of the symptoms you might see is probably helpful. And again, it's hard to do these as an inpatient, but more so from the outpatient perspective. So there was a really lovely systematic review and meta-analysis published in 2019, I believe, looking basically at what is the symptom burden in this population, and it's quite significant. So the majority of it here, you can see most prevalent kind of symptoms were pain, breathlessness, and these are all actually from ascites if you kind of extrapolate the data. So patients with like large volume ascites have a lot of back and abdominal pain, and they can't breathe. That's quite, it makes sense, but obviously this is a very, very common symptom. And then, as we kind of mentioned in the case before, muscle cramps, and I've seen this as an outpatient too. These are very difficult to manage, and they're very debilitating. Like this is kind of like a whole body thing often, and really, really affects the quality of life of these patients. Sleep disturbances are very common and very, at times, difficult to manage. And then with the myriad of all this, there's quite a significant prevalence of depression as a result, which makes sense. There are a number of validated symptom assessment scales, which are more so for research purposes, which we don't have to get into today. This is just a slide just to show that they exist. So what we'll try to talk about today is a couple things. So obviously, most of you here who are internal medicine residents will have a pretty good toolkit about how to manage things like ascites and encephalopathy. And the milieu of decompensating features of cirrhosis. I just want to focus on refractory ascites today because that is a more of a unique decision tree of things, and it's not as black and white as the guidelines might suggest. And then we'll talk a little bit about the symptoms of cirrhosis, namely things like pruritus, muscle cramps, sleep disturbances, and things like sarcopenia, and how to have an approach to those. So ascites. I like managing ascites. Most people don't, but every jar has a lid, I guess. So this is the most common decompensating feature of cirrhosis, and it develops in more than half the patients. Again, often characterized by pain, breathlessness, as you see patients come in with, over 10 liters of ascites fluid in their abdomen. It is probably one of the main drivers of impaired health-related quality of life markers. And it's actually very hard on the caregivers as well. So refractory ascites is common, I would say. I mean, not common, but it happens. Again, it's usually in about 5 to 10% of patients with cirrhosis and ascites. So yeah, scratch that. It's not as common, but these patients have a very high symptom burden and very high healthcare utilization. This is also very important to identify because prognostically, these patients don't have long to live because they are basically, if you can kind of picture in your head this profile of a patient with like hyponatremia, diuretic refractory ascites, or diuretic intolerant, where they have recurrent AKIs, and you can't really titrate their Lasix or Spiro above like 40 and 50, basically. That's the patient where you have to be very careful about what you're going to do with their management. Because basically, they will all basically go into HRS. That's the physiology you need to be aware of. So AASLD defines this in a different way. So there's resistant ascites, which is basically persistent ascites despite maximally tolerated doses of diuretics. And they would define that as a spironolactone of 400 and furosemide of 160, which is like insane. Like I've never seen anybody get to Spiro of 400. You'll put somebody into hyperkalemic arrest or like dialysis before that happens. There was actually a very large study looking years ago, I think in the 80s, about the majority of patients that end up getting peritoneal venous shunts. So they had, by definition, kind of refractory ascites, and they were on like 40 to 80 of Lasix and like 100 to 150 of Spiro. So like pretty moderate doses at best. This intractable ascites is kind of the picture I want you to kind of think about in your head, which is those patients with hyponatremia and recurrent AKI, and that's that phenotype of end stage portal hypertension. So once you've kind of had a sense that that's what's going on, there's really no role for diuretics anymore. I've seen a lot of times on the ward where, patients will be restarted on Lasix 40 and Spiro 75, and then 72 hours later, their creatinine bumps up and their sodium drops. Once you see that happen, just stop diuretics. There's really no role for them anymore, because at that point, your job is to manage the symptoms of their ascites. You're not trying to get rid of it, okay? So it's okay for them to have ascites, but you just have to figure out how can I minimize the impact on their life, because at that point, they don't have much time left. I would suggest if patients are hypotensive, and they often are because of the myriad of circulatory dysfunction, is to start midodrine for them on all these patients. There's very little side effects to them. The most common thing being like bradycardia. I usually start at 5 TID, and there's actually some evidence, I didn't finish that line there, but basically there's some evidence that these patients actually will have more diuretic responsive ascites natriuresis. There's little harm, and I think just having them have a bit more systemic vasoconstriction actually helps them feel a lot better too, at least less orthostatic. At this point, I would probably stop. If they're on a beta blocker, just stop those, because again, I've seen a lot of cases of worsening circulatory dysfunction and predisposing them to things like AKI and hyponatremia. And then again, just avoiding things that might affect their kidney function, like we usually do with NSAIDs and nephrotoxic medications. So the management algorithm for refractory ascites is such. So basically, they need recurrent large volume paracentesis. Unfortunately, that often happens currently has to happen in hospital or through interventional radiology as a bridge. At that point, you then have to make a decision about what to do next. So if these patients have preserved liver function, so like a low MELD, then you should be thinking about TIPS for these patients, because that might be the cure for them, and they actually will go on to have a relatively reasonable trajectory because their liver function is otherwise fine. It's just the portal hypertension piece. Or if they're not transplant candidates, the other part of this should be like, well, should we think about transplant for these patients? Is looking at their kind of MELD score, and if they meet criteria based on that, is this person palliative? So if this person has a life expectancy in the matter of months, then we should really be thinking about end of life planning and symptom management, which is basically manage them with an indwelling peritoneal catheter, which we'll talk a little bit about in a bit. So what are the logistics of outpatient large volume paracentesis? So we know that the concept works. So there's this kind of retrospective analysis in the UK looking at over 13,000 patients who had cirrhosis and ascites in the last year of their life, who had access to a day hospital to get large volume paracentesis, and they predictably had, lower healthcare costs, reduced length of stay in hospital, and a lower probability of getting readmitted after being discharged. Makes sense. How possible is that locally? Very low. So it is very difficult to do this for our patients here. They mostly come to the emergency department, usually sent by whoever's quarterbacking for them, whether it's internal medicine or hepatology. Sometimes if you go to VGH, the POCUS team can see these patients and discharge them. Oftentimes, though, as we see, they have to be admitted. So when to think about a tip? So basically, if patients are requiring large volume paracentesis every 1 to 2 weeks, their liver function is preserved, as we said before, this should be a conversation with a hepatologist to then, pull the string on getting a TIPS and having that conversation with IR. The things that might rule that out is if they have, again, poorly controlled or severe HE, with an emphasis on poorly controlled. So patients that have like grade 1 HE, they're on lactulose, that's a cautionary measure. It's not an absolute contraindication. So we should still think about it at that point. And again, this, as we'll talk about, this should be a multidisciplinary discussion. If they have cardiac dysfunction like systolic or significant diastolic dysfunction or significant valvular lesions, that can put them at risk for post-TIPS cardiac dysfunction and heart failure and actually cardiac arrest. So that tends to be a contraindication. Again, MELD greater than 18, it's just because they have, once you shunt the blood flow basically from the portal vein into the IVC, they can actually lose a good portion of blood supply and actually go into ACLF. So these patients, they tend not to do. There's also like factors of frailty and sarcopenia as well as age, which also play into that as well. So my hopes for the role of TIPS, because this comes up a lot as MRP on CTU, is that, we'll often try to, call transplant, oftentimes for a variety of reasons, usually active alcohol use disorder or like poor social, situation. They're not going to be candidates. And then we're faced at dispositioning these patients and figuring out what to do, what's best for them. So right now it's kind of dependent on one person, but I feel like multidisciplinary rounds are how the future of medicine is going for these complex patients. There's like, large polyp rounds, there's liver tumor rounds, there's IBD rounds. There should really be a portal hypertension rounds with, hepatology, internal medicine, interventional radiology, cardiology, who discuss these patients and determine what their best course of action should be. Should this person be referred for transplant? Should this person be referred for a TIPS? Should they get an indwelling catheter and referred to palliative care for more symptom management and palliative trajectory? That's really ideally how this should go, in my opinion. So what about indwelling peritoneal catheter? So there was actually a systematic review, including about 18 studies, one RCT, which had like one patient in each arm, and then mostly kind of retrospective and observational studies with a total number of 167 patients. So not that large of a sample size, but the best we can do right now in terms of data. So their mean survival was in keeping with historical standards. So like between 5 weeks and 5 months. So again, very hasty trajectory to palliation and death. Non-infectious complications were not that common, so less than 12%, usually leakage at the site, which resolves, and then occlusion of the tips. 2 bleeding complications, which resolved, mostly just a bit of hemorrhagic ascites, but nothing that required any intervention. And then infectious complications are the kind of the biggest issue in the back of people's mind, which is like, are these people going to get infected? And based on this study, only 12% had this, and interestingly, only 12% of the population, this sample, were on suppressive antibiotics. So I will say my personal anecdote is that I don't know how truthful that is. Like the 2 or 3 patients that I've seen, like 2 out of 3 patients I've helped with tank off, or like the tank off catheters, the one in Victoria, 2 of the patients developed bacterial peritonitis like within a month. So it's not without its risks. And I think that has to be managed and communicated to the patients as well. So this is kind of what I do. So the Plerex is what I think what we use in Vancouver. The tank off catheter is just the same thing, but different brand used in Victoria. So basically, once the decision's been made, you're basically submitting BC Palliative Care benefits so patients can get home supports and catheter care. I would strongly suggest putting them on suppressive antibiotics, whether that's the same SPP prophylaxis like Cipro, Septra, or even amoxicillin. And then the way I write the orders is usually taking off 1 or 2 liters a few times a week for nurses to do. And then that basically mitigates them having to get regular albumin. And then you're basically just managing symptoms. The goal here is like no abdominal pain. They can eat, right? Because sarcopenia is a huge issue, and they can mobilize. That's kind of your goal with these things. So this is a quick note about gynecomastia, because again, you'll see this when you're really titrating up spironolactone for these patients. And what I do, and I've actually had pretty good success with, is switching them to a Plarinone. It's very expensive, but actually you can just submit a general special authority and get this covered. And the dosing is about 2 to 1. So for example, like if you're on 25 of spironolactone, then 50 is usually what the dose of a Plarinone you're going to target. I usually see the gynecomastia and like painful gynecomastia usually around dose of 150 to 200, but that's variable. So let's briefly talk about muscle cramps. I think we have a bit of time here to kind of get through this last few slides here. So very prevalent. The pathophysiology is poorly understood. It's thought to be something to do with ATP deficiency. Not really great management for this stuff. I've tried things like taurine, which some seem to help. There's some small RCTs showing reduction in cramps with baclofen. There's a recent RCT called the PICKLE study, suggesting that if you take pickle brine, so like a teaspoon of this at the onset of cramps, it actually reduces the cramp duration, with actually no evidence of like worsening ascites from like the sodium load. So whether that's something you want to recommend to patients, I tried it in one patient, it didn't work, but she already had a number of other kind of failed treatments as well. There's also potentially some evidence for quinine and branched chain amino acids, which are quite expensive and not really very well available. There's some evidence for like chronic albumin for these patients too, but again, that's not something we're able to do right now very often. Pruritus, again, most of the evidence for this is from like cholestatic liver disease like PSC and PBC. I would always try things like non-pharmacologic things first. So a lot of the times these patients have like dry skin and cirrhosis, and just tell them not to use harsh soaps and use like Aveeno moisturizers. That by and large will help a lot of patients. For the ones that are refractory to that, I would try to avoid things like antihistamines, because again, I've seen people precipitate encephalopathy just on like low doses of hydroxyzine, which the main thing is just sedation, right? Cholestyramine is still first line, but difficult to take because you have to take basically 1 hour after or 4 hours before other medications. So it becomes a bit of a logistical nightmare. Naltrexone, rifampin again is quite expensive and I think difficult to access. Naltrexone is something that I found some good success in, and you can kind of like get away with prescribing it for this if you sign your provider agreement and you just don't tell them why you're giving it to them, which is maybe I shouldn't say on a grand rounds, but fourth line is SSRIs. But again, this is sometimes difficult to manage for the refractory cases. Sarcopenia is something that is very, very prevalent. And I will just plug into your minds that like keeping patients NPO in hospital when they have decomp cirrhosis is like you and I not eating for 3 days. Okay. So that's the caloric deficit that they're in. So you're really recommending like good nutrition for them. All these patients should be followed by a dietitian in hospital. Ideally as an outpatient, they should be getting basically tons of Boost and Assure. Late night snacks like, peanut butter and bread, Greek yogurt at night, to basically make sure that they're not having too long of a fast overnight and going into significant sarcopenia. Sleep disturbances, I would say like if they're not on lactulose, most of this is usually minimal encephalopathy when they're coming in with like, insomnia. So try them on lactulose. If that doesn't work, they're still having it, you could even consider rifaximin. There's some evidence for hydroxyzine, but again, be very careful in the patient that has a history of encephalopathy. Melatonin's safe. Anything beyond that, again, it's going to be on a case-by-case basis, but I would try I would try to avoid other kind of neuroactive medications that we normally use. Definitely avoid dead drugs and all that stuff. So these some recommended resources. I think we're almost out of time here. For your interest, for the learners here, for more information on symptom management, cirrhosiscare.ca is a fantastic website through the University of Alberta, which basically is like the mecca of flow charts and decision trees for decompensated cirrhosis, and then a few of other kind of very, very helpful high yield topics for management of complications of advanced chronic liver disease and palliative care stuff too. So the key takeaways, which are pretty obvious at this point, is that patients with decompensated cirrhosis basically have a short-term, high mortality, high symptom burden. Many will not be eligible and will die waiting for a liver transplant. Just recognize the poor prognostic signs, things like high MELD, refractory ascites, declining functional status, recurrent hospitalizations that are signals that these patients are more imminently, at end of life or on a palliative trajectory. Do your best. Basically, that the time you should be initiating these goals of care conversations is when they first decompensate, as I kind of was saying before. Have those conversations with them. Use the best case, worst case scenario if that's helpful for you, and then reassess them often. At the end of the day, the management of this is just good palliative care, and try your best to treat their symptoms. So my hopes for future direction for this patient population is kind of a dedicated cirrhosis pathway in Vancouver with a palliative care lens, a low barrier option for outpatient paracentesis, which is in the works, multidisciplinary portal hypertension rounds for these patients for better kind of care coordination for management of their portal hypertension. And then the long-term plan is potentially to have palliative care expertise as part of BC transplant pathway. So that's my talk. I'll leave room for questions from the chat or from the room.
Thanks, Dr. Pai. Great talk. So we have about 5 minutes for questions. Maybe I'll start with the first question, if that's okay. So you presented a few of the scores to assess for advanced liver disease. So which one do you think is the most practical to use, like in patients that we would see in CT or for acute patients, inpatients?
Yeah.
Just as a rule of thumb, maybe that would be helpful.
It's a good question. I think like the MELD score is probably what we use as our go-to. Again, it's quite dynamic and it changes from day to day, right? So that gives a good sense of like if patients are getting worse or improving. And then I always look at the clinical parameters too, mostly like what their symptoms of portal hypertension are. So if they have, again, like this milieu of end stage portal hypertension, the patients with like hyponatremia, recurrent AKI, it's very difficult to control ascites. That is more of a prognostic sign for me that this person is at an inflection point. And then functional status. So again, PPS is more so, for the end of life stage, but I will get a sense of like, how much they can do at home and how that's changed and over what period of time that's changed. I think that's very important to suggest that things are on more of a downward spiral.
Great. Thank you. Any other questions from, maybe we'll start online first. Any questions online?
I have a question.
Oh, go ahead.
Hi, thank you so much for the talk. It's so good, so excellent. We took down lots of notes here at Tri-Cities. I just have a quick question around prognosis, pending on the source of the cirrhosis. So does the prognosis change if the cirrhosis is due to underlying cancer versus non-cancer prognosis? And if it does, then, because I see you nodding, what would be the implication if the cirrhosis is due to underlying liver cancer versus non-cancer diagnosis?
Yeah, it's a good question. So I think like the question I'm being asked is if this person has like hepatocellular carcinoma in addition to their cirrhosis, is that what you're getting at? So yeah, I didn't include that because in this talk, because it's kind of its own separate topic that's managed in a different area of oncology. But basically, yeah, that like if somebody has like multifocal HCC and is out of like tumor volume criteria for transplant, then there's really they're like at that point palliative in the sense that they could be on like immunotherapy and mostly symptom management at that point. So there's no curative option for them, including transplant. But you bring up a good question about what the etiology of the cirrhosis is, and that's another talk in and of itself, because there's this kind of concept of like stabilization and recompensation if you can treat the underlying pathophysiology. So that the examples they give are things like alcohol. So if somebody comes in with like acute alcohol hepatitis and they develop like ascites and all that, they have cirrhosis.